Andrela.
Indian Chess Society welcomes you to this webinar. ICS is committed to providing an in-depth understanding with take-home messages at the end of every webinar. We are conducting a series of informative webinars every fortnight. Today, our discussion is on adult respiratory vaccination. I sincerely welcome our moderator, our very own Professor A.G. Ghoshal, ex-president of Indian Chess Society and medical director, National Allergy Asthma Bronchitis Institute. ICS is grateful that you have accepted this invitation, sir. I request you to go ahead and begin this session. Over to you.
So, good afternoon, everybody. And you have already listened about the name, the title of this webinar, Adult Respiratory Vaccination. This is from Indrila. Actually, I had a little more. Miles to go. Adult respiratory vaccination, miles to go. I don't know whether you remember, Miles to Go was a very famous song from the Canadian singer in 1997, I think. And it was hailed as one of the greatest love songs of our civilization, Miles to Go. But actually, when I look at it, I can see a lone horse rider just trotting over the forest amid snow, and miles to go before I sleep is actually the line of a poem from Robert Frost in 1923. So a bit down memory. In 2016, our institute, National Allergy Asthma Bronchitis Institute, Kolkata, NOBI, had a position paper on adult respiratory vaccination published. In 2016, some of my colleagues criticized and even mild ridicule that what is the purpose of all this? You need to treat them in time. And then are you playing for someone else? Unfortunately or fortunately, post-pandemic, the scenario is all changed. Now, before we write vaccination, patients ask us about vaccination. So at least the mindset of the patients have changed. But as Mahatma Gandhi said once, are we changed in our mindset? So today's webinar is just in-depth discussion on this aspect, adult respiratory vaccination, miles to go. And we have with us Dr. Parvez Kaul. Parvez is a silent researcher with many publications, and he is the editor-in-chief of Lung India, and Lung India has got to a new height under his leadership of Dr. Parvez Kaul. I think the rest of the thing is Director SKIMS, ex-officio secretary to the government of J&K, are just laurels in his hat. But basically, my take on him is a silent, serious researcher doing his job silently over the years. And then we have Dr. Agam Bhura, and I got today this writing that what Agam wants to be known as chest physician Mumbai. And very apt, because the whole India knows him. Why he should write some degrees, some affiliations. Just write Agam Bhura. Just write S. Jaishankar. Something like that. And everybody will understand who is speaking and what we expect from him. What we expect from him is, for last probably 35 or 40 years, we are meeting at different towns, different forums. How is Agam? As bad. So I hope he remains as bad for the rest of his career. And then we have our Indranil Haldar. He is my colleague. He did his MD with me. He is the Professor Head, Department of Medicine, Kalyani. He is East Zonal Chairperson previously and Chairman of State Chapter Indian Chess Society. And he was part of our Indian guidelines on adult respiratory vaccination, pioneered by Nobi, Kolkata. And last but not the least, we have Paramej Apap, representing Secretary Kerala Chapter of Indian Chess Society and Head Department of Pulmonary Medicine, DC Hospital, Kochi. He represents the new generation of pulmonologists, breaking new grounds for us in the international scenario. So we have a very interesting galaxy of speakers today. Let us start with Parvez for a brief but broad overview of adult respiratory vaccination, what we are heading towards in coming future. Dr. Parvez Kaul, please.
Thank you, Ghoshal sir. Thank you, Indian Chess Society. Thank you so much for this very kind and generous introduction, sir. I'm honored to be presenting this webinar. I hope you can see my slides. I have shared my slides. Can you see? Okay.
Yes, sir, we can.
Okay. I've been asked to talk about adult respiratory vaccination and where we stand today and what are the current recommendations. So why is adult vaccination important? As Dr. Ghoshal said, miles to go for a long time before we sleep, as Robert Frost says. So if you look at the over 65 proportion of the population by countries, and these are a few of the countries that are depicted here, you can see that from 2016, represented in blue columns, to 2030, that is represented in the yellow columns, we can see that each country would be expecting an increase in the number of population that would be over 65. And in 2035, that will be the first time the US is going to experience a change in the number of children compared to adults. Adults would outnumber those more than who are under 18 years. So by 2060, we expect that the 23% of the proportion of the population would be more than 65 years of age, compared to only 20% of those who would be younger adults. Compare this with India, and these are data from rest of the most of the states of the India. And as you can see, from 2013, 2011, when 31% of the population were children, that was less than 15 years as defined in India, this number is going to shrink to 20%. So that means 80% of the population would be 15 years and above. So that is a sizable number of population that we are going to have to deal with. And unfortunately, our vaccination strategies as of now are focused on children alone. And we are talking of respiratory disease. The global burden of respiratory disease, chronic respiratory disease is increasing. And if we talk about this burden of chronic respiratory disease, it is increasing in India from 28 million in 1990 to around 55 million in 1917. And if you look at the top public health interventions in 2001 to 2010, the bigger achievements have been like cardiovascular disease prevention, occupational safety, cancer preventions, public health preparedness, tobacco control, maternal infant death, prevention and control of infectious diseases. But what stands out at the top is vaccine preventable diseases. And it is because of the achievement of our ability to to actually reduce their prevalence. We have been able to reduce the morbidity of many of these diseases like smallpox, diphtheria, poliomyelitis, measles by about 99 to 100%. Some of these stand eliminated totally, and whereas some are still prevalent in some of the developing countries. When we talk of respiratory vaccines, the major respiratory vaccines include influenza vaccine, the pneumococcal vaccine, the pertussis, COVID. Now TB vaccine is being talked of in adults as well, zoster vaccine, and the new kid on the block, that is the RSV vaccine. Looking at why is vaccination, why is chronic respiratory disease important? This is what we looked at as a part of the global burden of disease, which was published in 2020. We looked at the prevalence and attributable health burden of chronic respiratory disease between 1990 and 2017. And as you can see, these are the data from 1990, and these are the data from 2017. This is for females and this is for males. And in 2017, an estimated 550 million people worldwide had a chronic respiratory disease, and nearly 40% increase compared to the number that was there in 1990. This talks of the mammoth magnitude of chronic respiratory disease that we have to deal with. And infections are common in these. We looked at chronic respiratory disease, influenza as a cause of pandemic and seasonal influenza virus, and we demonstrated for the first time that influenza seasonal as well as pandemic influenza was responsible for causing acute respiratory illness in Kashmir that was close on the heels of the 2009 pandemic. And then subsequently, as a part of the network of Indian Council of Medical Research and the Center for Disease Control in the USA, we had 8 sites in the country which were looking at the influenza seasonality and surveillance. And we found that influenza significantly causes ILI as well as SARI in India. In Kashmir, we do see patients with community-acquired pneumonia also, and as all of us see, we looked at the routine bacteriological studies of these patients and also looked at serology and urinary antigen for chlamydia, mycoplasma, legionella, as well as for pneumococcus. And we also did for RT-PCR for influenza. And this is published in Lung India. As you can see, I mean, Streptococcus pneumoniae was the commonest pathogen that was isolated from these patients, but 15% of these patients did also have influenza, mostly during the times when we have influenza as a seasonal circulation in Kashmir. Then influenza does contribute significantly to the acute exacerbations of chronic obstructive lung disease as well. We recruited around 500 patients and found that 8%, that was 40% of the AE-COPDs were attributable to influenza, and those patients who had influenza were more likely to die during hospitalizations as a result of acute exacerbation of chronic COPD. This paper that came last week, in fact, this looked at the age differences in comorbidities presenting symptoms and outcomes of influenza illness requiring hospitalization. There's a global network of researchers, which is called the GIHSN, Global Influenza Hospital Surveillance Network, and Indian representation is here in this. And we demonstrated of around 16,000 enrolled patients, 21% had lab-confirmed influenza. And what we demonstrated that middle and older age and history of underlying diabetes or chronic obstructive lung disease were associated with increased odds of death and ICU admission. Male sex and influenza vaccination were associated with lower odds. So influenza vaccination is probably the most important intervention that can help you prevent influenza, prevent developing complications of influenza, and prevent developing death if a person develops severe influenza. So we look at certain studies that looked at the efficacy of influenza vaccinations in patients of chronic obstructive lung disease. A Cochrane review in 2018 looked at influenza vaccinations in COPD patients, and it found that it reduces exacerbations. Another study looking at the risk of respiratory failure in chronic obstructive lung disease and influenza vaccination demonstrated that there was a lower risk of respiratory failure in geriatric patients who had received influenza vaccination. Another study that was published in the Journal of Infectious Diseases in 2020 looked at influenza vaccination in older adults with chronic obstructive lung disease and demonstrated that moderately effective influenza vaccination was there in lowering the lab-confirmed influenza-associated hospitalization in COPD. So it reduces exacerbations, reduces risk of respiratory failure, reduces influenza-associated hospitalizations. Another paper just published last year looking at if influenza vaccination does improve the survival in elderly patients with chronic obstructive lung disease, demonstrated that influenza vaccination was related to a lower risk of all-cause and cause-specific mortality among elderly chronic obstructive lung disease patients. Another study, which was published in Scientific Reports, a very credible journal, looking at influenza vaccination providing lab-confirmed influenza in chronic obstructive lung disease, again demonstrated that there was an average effect of current seasonal influenza vaccination, which was moderate to prevent influenza in chronic obstructive lung disease patients. And just 2019 looked at the effectiveness of influenza vaccine in preventing hospitalizations as a result of influenza in patients with chronic obstructive lung disease. Large study, 4,000 plus patients, and demonstrated that it substantially reduced influenza-related hospitalizations. What about asthma? Another chronic respiratory illness that bugs us all. So as per the CDC, asthmatics are at a high risk of developing serious flu-related complications, and asthma is one of the most common medical conditions in children and adults hospitalized with flu. So what does asthma do? We know that asthma patients have swollen and sensitive airways. So what influenza does is causes further inflammation of the airways, triggers asthma attacks, leads to acute respiratory diseases, and leads to development of pneumonia. So these are a few of the studies which looked at the efficacy of influenza vaccination in patients with asthma. So this study was published in the Journal of Asthma, demonstrated that influenza vaccination could be a protective factor for patients with asthma. And another study, which was published in the Canadian Medical Association Journal, looking at influenza vaccination in the current and previous seasons in preventing influenza among patients with asthma, showed that influenza was reduced by nearly half among patients of asthma who had exposure to an influenza patient. What about influenza vaccine in people with asthma over a 6-season period? Again, influenza vaccination gave a meaningful protection against lab-confirmed influenza in all asthmatics across all seasons. Another study looked at it and demonstrated that influenza vaccination reduces influenza infection and asthma attacks as well. Our very own clinical practice guidelines that were actually led by NABI and ICS and NCCP. And the recommendation was that for chronic respiratory disease, which included asthma, COPD, bronchiectasis, interstitial lung disease, and chronic smokers, 1 dose of influenza vaccination annually was recommended by ICS and NCCP guidelines. So one of the questions that comes to us is, when do we vaccinate? What is the pattern of vaccination across various cities of India? And we know that influenza vaccine is divided on the basis of geographical location. We have a northern hemispherical vaccine and we have a southern hemispherical vaccine. So if you look at it, this is the influenza equator. And if we look at India as a whole is located in the northern hemisphere. So we looked at 2 cities in India, that is Srinagar and Delhi, and tried to figure out what is the pattern of circulation of influenza in Srinagar and Delhi that are just 500 kilometers apart. And what we found was that whereas Srinagar has a northern hemispherical pattern of circulation of influenza, Delhi predominantly has a southern hemispherical circulation, which has the predominance during summer months, whereas Srinagar has the predominance of influenza during winter months. So we suggested that the geographical equator is not relevant for NH and SH seasonality of influenza, and probably influenza equator is located somewhere at the 30-degree north latitude, and because this latitude is what divides the influenza circulation in big landmass countries like China and Brazil. So this last year, we wrote a small piece in the Lancet Global Health that we need to redefine the influenza equator based that because on the findings that in China, Brazil, and India, which have a large landmass, there are sub-regional variations of circulation of influenza, which are related to what we call as the influenza equator rather than the geographical equator. Then influenza vaccine effectiveness also is sometimes not related to the circulating strain and the vaccine strain. There may be sub-molecular changes that can contribute to a poor vaccine effectiveness. Even if you have the same virus that is circulating in the population and the virus is the same in the vaccine also, there may be certain mutations which may lead to a poor vaccine effectiveness. And COVID had a significant, profound effect on the circulation of influenza. As you can see, these are the various seasons where we had high influenza. And then once COVID struck, there was absolutely no influenza at all, till recently when influenza has come again. So influenza vaccine is something that needs to be given to people with chronic respiratory disease. And the vaccines that we have available are the inactivated vaccine, the live vaccine. We do not have the cell culture vaccines. We do not have the boosted vaccines, the high dose vaccines. But there is a large body of researchers which are trying to look at something which could be across all species. And that was published last year in November. A multivalent nucleoside modified messenger RNA vaccine was developed, which looked at, which was responsible for protecting against HA antigens of all 20 known influenza A and B viruses. And that would be the panacea, that would be the universal influenza vaccine, but it has a long way to go before it can be made available. So flu vaccine helps us take a detour. I mean, if we are going on to the line of severe flu, you take a detour, you have a chance of not getting influenza, you have a chance of not getting a severe influenza, and we have a chance of not getting death if a person gets influenza, if a person is vaccinated. Unfortunately, there's a few of the studies in patients with chronic obstructive lung disease, in pregnant females, in diabetics, and in patients with heart failure, where we demonstrated that despite standing instructions by various societies, the vaccination uptake was very poor, including those more recently in healthcare workers. We found that even though vaccination uptake was up to 71% in South India, but the acceptance rate dropped to only 36% when vaccination was not recommended as a part of pre-employment requisite. So influenza vaccination, a lot has to be done before its uptake is optimal in most of the high-risk populations. Next, we come to COVID. COVID, I don't want to spend much time on COVID vaccine recommendations. COVID is still evolving. We probably need to follow the government recommendations regarding primary and booster vaccinations as are relevant to a particular country, including India. Next, we go to pneumococcal vaccinations. The pneumococci we know are gram-positive diplococci, have a polysaccharide capsule, have nearly 100 known serotypes, and the polysaccharide capsule is the main determinant of virulence, has a property of preventing mechanical clearance of the pneumococcus, inhibits opsonophagocytosis, and restricts autolysis and reduces the antibiotic exposure. We know that as you age, there is a higher risk of hospitalization and comorbidities. So 60% of older adults have 2 or more underlying medical conditions, and COPD and diabetes are predictors of hospitalizations. And as we go on increasing in the number of medical conditions, as you can see from in different age groups, as the number of medical conditions goes on increasing, as is seen 3 medical conditions in patients with blue columns, there is a profound increase in the possibility of getting an invasive pulmonary disease. So as we grow in age, our chances of getting a severe pneumococcal infection go on increasing. And that is because of a lot of changes that happen because of aging. They are because of immunosenescence, that is dysregulated and impaired functionality of immune cells, and impaired functional ability of a number of organs, including the bone marrow, which is skewed towards myeloid series than the lymphoid series. This was a study which I was fortunate to be partnering in. We looked at the global, regional, and national morbidity and mortality estimates and the etiologies of lower respiratory tract infections in 195 countries between 1990 and 2016. We did it as a part of the GBD study, and it was seen that in nearly 2 million deaths occurred as a result of lower respiratory tract infections, and Streptococcus pneumoniae was the leading cause of lower respiratory tract infection morbidity and mortality globally. And more recently, we did another study, looked at the 33 bacterial pathogens in 2019. We looked at the GBD data and found out that more than half of all the global bacterial deaths in 2019 were due to 5 bacterial pathogens: Staph aureus, E. coli, Strep pneumoniae, Klebsiella pneumoniae, and Pseudomonas aeruginosa. And this is where Streptococcus pneumoniae figures. If you look at the estimated burden of pneumococcal disease in the US in adults, in 2017, more than 100,000 patients were hospitalized due to pneumococcal pneumonia. In 2019, around 30,000 IPD cases and 3,000 invasive pneumococcal deaths occurred as a result of pneumococcal disease. And 43% of these occurred in adults aged more than 65 years of age, and 48% in those aged 19 to 64 years with risk-based indication. So more than 90% of the current adult invasive pneumococcal burden disease is in patients who are aged 19 to 64 years. We looked at data in India also in adolescents and adults, and this was a systematic review done of adolescents and of around 1,435 patients, and nearly 20% of these patients, community-acquired pneumonia, were attributable to Streptococcus pneumoniae.
And a significant number of countries. This is the current...
This is... COPD in pneumococcus in COPD can cause 10 to 15% of exacerbations. However, it doesn't have a great role in stable disease. These are the current and pneumococcal vaccines. I'm going to talk about it in subsequent slides. And if you look at the duration of protection, it is up to 15 years, no decline for PCV. And obviously PCV has a better protection than the PPSV.
So
society recommendations, I think there is some
complicated, despite being actually by most of the societies in the world, including various societies of physicians in nations. We at the
this is a clinical practice guideline which shows that Indian recommendations for pneumococcal vaccination, where we have recommended PCV 13 followed by PPSV 23. What are the challenges to current vaccination strategies? Only a small subset of 100 serotypes is targeted. There is emergence of non-vaccine serotypes. Uncapsulated Streptococcus pneumoniae can occur. There can be antibiotic resistance.
So based on
current and recommended options for an age-based recommendation are, this is the current policy, which is PCV 13 followed by PPSV. Whereas people who have chronic medical conditions, cochlear implants, CSF leak, or immunocompromising conditions, both PCV and PPSV are recommended. And we know that there has got to be a interval of around a year. And if we have a requirement of giving them together more quickly, then at least 8 weeks should be between the PCV 13 and PPSV 23. This is what is prevalent in most of the countries of the world presently. However, what happened in 2021 that PCV 15 and PCV 20 were rolled out quick succession, PCV20 first, followed by PCV15. And the proposed policy option, which has been recommended now, is a single shot of PCV20 or a sequential administration of PCV15 and PPSV 23.
And it was.
If you look at the advantages of PCV20 alone versus the disadvantages of PCV alone, PCV20 alone is an acceptable and feasible option to implement as single vaccine option. It is cost saving in cost effectiveness analysis. It is expected to provide better protection for the serotypes covered by PPSV alone. However, the disadvantage is that clinical significance of lower immunogenicity versus PCV13 as of now is unknown. There are no data in immunocompromised adults, and losing protection against PPSV 23 non-PCV serotypes is there. The disadvantages of combining PCV 15 plus PPSV 23 are logistically, it's more challenging to administer the two vaccine series. We need to know the vaccination history to correctly complete series, and it can result in the lower serotype coverage if series is not completed. So when should we vaccinate? At age 50 versus 65 years? In favor of age-based recommendation at age 50, it may reduce disparity in disease burden in adults aged 50 to 64 years, may provide more opportunities to vaccinate adults before they develop underlying conditions. However, those who speak in favor of age-based recommendations at age 65, they say that the potential for waning immunity makes it favorable to vaccinate later in life when risk of disease is higher. It is consistently cost-saving in cost-effectiveness analysis, still provides some opportunity for high PCV coverage in adults versus this. So the newer paradigm for pneumococcal vaccination is that, as of now, adult vaccination has to take a stronger route in India, as Professor Ghoshal said, miles to go before we sleep. We need to have routine surveillance for pneumococcus. We need to know what are the serotypes that are circulating so that we have a serotype targeted vaccine. PCV20/PCV15 plus PPSV is the simplified option. Newer conjugate vaccines may need to be rolled out, and we might have to look at multivalent protein vaccines, hybrid vaccines. They may be the future of.
Concluding, ladies and gentlemen.
Another study that I must draw your attention to was one which was done in Kashmir last year, and we published the RSV among children hospitalized with severe acute respiratory infection, and we demonstrated in around 5,000 respiratory illnesses, nearly 62% were positive for any virus, and RSV was the commonest virus in around 30% of them. So since we are not talking of children, but we are talking about adults here, the news is that on 4th of May this year, the US FDA decided, based on data from ongoing trial, which involved 25,000 adults aged 60 or older, that RSV vaccine was approved for older adults. The trial demonstrated that a single dose of the vaccine was nearly 83% effective at preventing lower respiratory tract disease caused by RSV, and nearly 94% effective at preventing severe disease. So then this was the reason for an interim direction that led to the US FDA approving the first RSV vaccine in the US for older adults. We also have recent recommendations for whooping cough pertussis vaccinations, be it DTaP, TD, Tdap, or Tdap. Any adult 19 years of age or older who has never received a dose of Tdap should get one as soon as feasible. Administer Tdap regardless of the interval since the last tetanus or diphtheria toxoid containing vaccine, and it should be followed either by a TD or a Tdap shot every 10 years. And when feasible, people who are older than 65 years or older, they should get a Boostrix, which is a higher dose, and we should not miss an opportunity to vaccinate any person aged 65 years or older with Tdap. Talking of another vaccine, which is Haemophilus influenzae, which was in a lot of fashion some time back. However, this study came last year, which looked at the non-type of Haemophilus influenza and Moraxella catarrhalis vaccine for the prevention of exacerbations in patients with chronic obstructive lung disease. It was a multi-center, randomized, placebo-controlled, observational, blinded proof of concept phase 2b study. And what the study demonstrated that the vaccine administered to patients with COPD did not show any efficacy in reducing the yearly rate of moderate or severe exacerbations, even though there were no safety concerns identified. Vaccine hesitancy is a major determinant of the uptake of vaccine, and it has its various determinants in different regions. And these are some of the determinants in Europe. We had COVID vaccine hesitancy, and we know how so much of misinformation and disinformation was rife, and that contributed significantly to vaccine hesitancy. But there are other factors of the people are not, there's a disconnect between the healthcare workers' knowledge and practice, and people are bothered about the safety and efficacy. And those concerns have got to be taken care of once you're rolling out an adult vaccination policy. However, what we demonstrate was that the biggest barrier to influenza vaccination in this particular study in pregnant females in India was a poor sensitization to the care provider, because we looked at around 1,000 pregnant females, asked them whether they were vaccinated against influenza. They said no, none was vaccinated against influenza. Whereas once we asked them parallelly whether they were vaccinated against tetanus toxoid or hepatitis B, all of them were vaccinated against hepatitis B or tetanus toxoid, which roots the practice of giving vaccination to the vaccine provider. So we need to have vaccine pathways. We need to have a pathway for vaccination, create an environment that informs, simplifies, and the steps process for individuals and populations to be vaccinated. Then we should be a vaccine national immunization, and we should have an adequate supply of the vaccines as well as that of the vaccinators. We should target public health messages on vaccinations. They are vital to building and maintaining a healthy society. We must understand and execute the steps to address situational and societal barriers reflecting social determinants of health, which is crucial to reducing immunization inequities. So what are the recommended adult immunization vaccines, which are respiratory vaccines? We use influenza inactivated virus, the LAIV, the Tdap, the zoster, the pneumococcal vaccine, and the Haemophilus influenzae vaccine, depending on the condition and not in conditions of, this is age-based recommendation, not in respiratory disease. And these are the respiratory vaccines, that is the influenza, Tdap, respiratory zoster vaccine, and pneumococcal vaccines. These are the recommendations. Vaccinations for adults with lung disease, COVID, yes. Haemophilus influenza, maybe. Influenza, yes. Pneumococcal, yes. Tdap, yes. Zoster, yes. If you are 19 or older and have a weakened immune system or 50 years of older, you should get 2-dose series of the Shingrix brand of shingles vaccine. That's what the CDC says. And if you are vaccinated previously against zoster, and now the new kid on the block is the RSV vaccine. I'll stop here and await any questions that would be relevant to my talk. Thank you so much for your attention. So you're muted, sir.
So you missed the thanks that I gave you. So thanks for very elaborative coverage. Actually, so I will summarize it for our audience. So at least we need 5. So influenza, pneumococcal, Tdap, zoster, and COVID. Age influenza, okay, question of debate and controversy, probably will be covered in coming days. And also we feel the need, one, aging elderly population, comorbidities, presence of highly vaccine preventable diseases, and also antibiotic resistance following indiscriminate use of antibiotics after they got ill from these organisms. So we now feel the need. We understand the barriers, partially of course. There are different arguments. Some say about the cost, depends. Some say about the coverage. In the West, most of the countries cover the insurance coverage for these vaccines. And also, probably availability of adult vaccination centers. But I feel basically it's a mindset that we need to change. We physicians need to change our mindset because post-pandemic, actually the people are ready to accept vaccination. So we'll discuss the way ahead. Now, let us go to our panelists, Dr. Agam Bora, Dr. Paramej Antapat, and Dr. Indranil Hal. Are the questions ready, Rupsa?
Yes, sir. Yes, sir. I'm showing it.
Let us get the slide. My first question naturally has to go to Agam. Agam, you are the opener. Anyway, you like it or not. So what are the vaccine preventable diseases for adults in India summarize? And what are the unmet needs in respiratory vaccination among Indian population? Agam, please.
Good evening, everybody. And I must put it on records. It was one of the best presentations that I've had. Thank you, Dr. Parvez, for that presentation. And of course, whenever Ghoshal sir is there moderating a program, it's got to be such beautiful, such interesting event. Sir, trust me, it was my dream to share stage with Parvez Bhai, with Indranil, with Parvez, and that too, when this event is moderated by none other than you yourself, Dr. Ghoshal. I can't thank ICS enough for giving me this opportunity and letting my dream come true. So since you started with miles to go, I remember that Rabindranath Tagore's one poem, one kavita where he says, Tobe ekla chalo re, or in Gujarati it is said, eklo jane, eklo jane, eklo jane.
Even if no one comes, you proceed alone.
If there is nobody, we must proceed alone. And that is going to be the message today. The society somehow has not picked up adult vaccination to the extent it should. And as sir said, you and me are to be blamed. Yes, it is all of us who are to be blamed. The list is endless. Look at the vaccine preventable disease list. You have, as mentioned in the discussion, you have influenza, you have pneumococcal disease, you have now shingles, that is herpes zoster, you have pertussis, tetanus, typhoid, chickenpox, measles, meningococcal diseases, HPV. Now, RSV vaccine is going to be soon available. And it is said that vaccine preventable disease is one of the most vaccination is one of the best strategy to prevent a big morbidity and mortality. The list is endless, and we can definitely make a big difference in our patient's life by giving them this vaccination. And the unmet needs, when I look at it, these unmet needs could be at various levels. It could be at society's level, patient's level, it could be at your and my level, and it could be at implementation level. I'm sure we would discuss all that as the discussion flows. Thank you very much.
Thanks, thanks, Agam. Actually, what you say can be elaborated by others. So, yes, I'll go to my next question. Okay, Rupsa. Indranil, better to take the baton from Agam. What are the challenges and opportunities you look for adult respiratory vaccination at the present moment? I have said opportunities as well.
Okay, sir. Thank you. Thank you, Agam. Thank you, for Dr. Parvez. And definitely, it's my opportunity to be here. So, sir, when it comes to challenge, practically the first challenge that I think is the lack of awareness. So, if I quote, there are few studies, in fact, by Rathi, which has shown that more than 80% of adults are unaware about adult vaccination. When it comes to adult vaccination, they think that vaccination is something which is for the children. Probably the second, again, challenge is lack of dedicated adult vaccination center. We have pediatric vaccination center. Who will give the adult vaccine? The pulmonologist, the physician, they are not in a position that they can give the vaccine, probably the pediatrician. So what happens is that when we write a pneumococcal vaccine or an influenza vaccine, they have to go to the pediatrician to take the vaccine or to the pharmacy house to take the vaccine. Again, the cost factor is probably another important challenge, because if you see the conjugate vaccine, which is costly, I don't know what the conjugate 15-valent or the 20-valent will come. So a cost of 4,000 rupees, influenza 2,000 rupees is definitely a problem. And you see, no insurance company is going to pay for the vaccine. Unless I don't know what insurance is there who gives coverage for the vaccines. So when it comes to the opportunity, so yes, there are a lot of opportunities for that. So what may be the opportunity is that we have to create awareness at the level of the medical college, awareness at the level of the postgraduate training program, and awareness from the society at large. So involving the key stakeholder for involving adult vaccination, and we can create different vaccination centers, and we pulmonologists or we physicians can take the lead role to make the vaccination center and start vaccination from our clinic itself. So that's all, sir.
Okay. But Indranil, awareness starts at home, isn't it?
Definitely.
So probably when you talk of society, let us talk of two societies present here. Association of Physicians of India represents, and India Chess Society, you, Parvez, and our Paramej represent. I am an old guard, so I am at the back. So probably we need to more awareness drives, which this webinar is a part. And again, the opportunity, again, I am sorry to use the word, the pandemic has been an opportunity. People has been much more receptive to the idea of vaccination. And there was a question of vaccine hesitancy. My personal feel is there was much more vaccine hesitancy in the West compared to our India. Indian patients still trust their doctors very much. Whoever actually in Bengal, the first vaccine was taken by 5 of us. I was one of them. And so we came in the newspaper to show others that this is nothing against. Okay, so I'll go to then Paramej, that is vaccine. Next, please. Is vaccine hesitancy a myth in the post-pandemic era? Paramej, please.
Good evening, sir, and all the ICS stalwarts for inviting me. Thank you very much. And it's a very lucid talk by Dr. Parvez called as usual. So as Ghoshal sir already mentioned, vaccine hesitancy. I was about to say about the vaccine hesitancy in my talk itself. So yeah, vaccine hesitancy depends upon which place are you living. Like if you are in West or in our part of the world. So leave alone the West, we will talk about our area. So as sir mentioned, COVID pandemic has opened up the door for all the individuals about what respiratory diseases are, what is the importance of protecting your lung, how can you prevent the infections entering into your lung, and how can you get out of that situation once you get into an infection. So we had several waves and of COVID infection. So, and people are also aware of how the COVID vaccination has improved the mortality and hospital admissions of individuals after getting a single dose of vaccine itself. Okay, so in that aspect, definitely the vaccine hesitancy has improved a lot, or as I would say, vaccine acceptance has improved a lot. It has paved a way or an opportunity for the treating physicians, or say, I would say pulmonologists, to mention about certain other adult vaccinations like the pneumococcal vaccine or the influenza vaccine or the Tdap vaccine or the shingles vaccine, that these patients can be used or should be used during their course of illness to prevent further exacerbations and admissions. So the vaccine acceptance has improved a lot as far as my practice is concerned. But if you can see the Western literature, yes, there was a bit of the, it's political, it's about the knowledge of the individuals, it's about the geographic area, it's about your psychosocial behavior, etc., etc. So in our part, yes, definitely it has improved a lot. Thank you.
Okay, I will remind you that during that time, this vaccine hesitancy, there was a moral angle, there was a political angle, and there was a pseudo-scientific angle. There was an extreme right group, particularly in the West, who are propagating against the vaccine. Mind it, Djokovic sacrificed one of his crowns because he will not take the vaccine. So, but again, Indranil, so what is the, next question please, Rupsa. What is the source of hesitancy? Rupsa, next question please. What is the source of hesitancy? I will come to Parvez rather. Lack of sound epidemiological data. Parvez, this is very clear.
Thanks, Gushal sir. I think this is a very important part of vaccine rollout strategy anywhere. Vaccine hesitancy is rooted probably in the lack of sound epidemiological data. People are not knowing as to what is circulating in their populations. That's true. We have poor surveillance. The surveillance that we have is very patchy. We have data from one region, and we don't have data from a parallel or adjoining region. So we have to extrapolate the adjoining region's data to the area. Then guidelines are there which are changing every time, and which is also true, and but that's a necessity because people are supposed to give vaccination according to the current circulation, and that is why it's an evolving science, and that might be causing a hesitancy as well. But what is more important is that people have an inherent fear of the vaccine side effects and do not trust that vaccines are effective. So the deficit in vaccine perceptions about vaccine efficacy and safety are two things that we found. And there are a variety of reasons. We asked people, why did you not take the vaccine? They said that it can harm my immune system. It can harm my joints. Why did you not take it? Because my doctor did not tell me. Somebody on the internet site said that vaccines can harm. So lots of things are important. Economic considerations, yes, in a small subset of population. Otherwise, generally, no. We have actually asked people whether they took vaccine. Once it was given free of cost, I think most of you know, 1 million doses of monovalent H1N1 vaccine were needed to be destroyed because there were no takers. So even if it was given free. So yes, a number of things do operate in the causation of hesitancy. And the most important thing is that there is a disconnect between the perceptions and practice, and there is a fear of vaccine side effects, and there is a lot of perception defect about the vaccine safety and efficacy.
Okay, Parvez, again I will remind you, there was one time a fear of persistent genetic changes after getting the RNA vaccine. So it was a huge storm in the West. Okay.
Very true, sir. Very true, sir. That's very right. That's very right. There was a lot of misinformation and disinformation. That was disinformation of pandemic, it was called.
So we have seen the vaccine hesitancy in COVID vaccine. There are a lot of reasons. Social was another important reason. What sir was telling, genetic mutation, some of the social media was showing some of the different bad images of taking vaccines that we have seen. Again, economic consideration probably is only when for pneumococcal vaccine, I think so. Otherwise, it's basically the social and the cultural factor that comes into play.
Indranil, I would like to say, sir, with sir's permission, the basic thing is that whenever a doctor prescribes a drug or a vaccine, trust me, people more often than not take it. It is rooted more so in the doctor's behavior or the doctor's prescription practice than that of the patient.
Exactly. So if the doctor believes it, that conviction percolates to the patient. So it ultimately depends on that. At the best, I may sound, the patient may ask the doctor whether he have taken the vaccine.
Yes.
Okay. The next question, please, Rupsa. Naturally, none other than Agam. How may we imbibe vaccination as an integral part of adult patient management as in children? That is another thing. Because before 2021, everybody thought vaccination is for children. Now, probably there is a shifting mindset and a shifting ecosystem also favoring adult vaccination. So, Agam, how may we imbibe this as an integral part of adult patient management?
Sir, to make it integral part of adult vaccination, we have to first understand what are the actual problems. We have to review the current scenario. And if I review the current scenario, what comes to my mind is, unluckily, there is no coordinated public health infrastructure to support the vaccination program as it exists in children. Of course, you and me are responsible. We have not done adequate work in this area. And as you rightly said, it's the responsibility of you and me put together. It's the responsibility of two big professional bodies like Indian Chess Society and API to work together to propagate this message. Unluckily, there is very poor coordination amongst healthcare providers in terms of this vaccine provision. As Parvez Bhai was saying, who would give that vaccine? If I prescribe a vaccine, he goes to his family doctor is unaware about vaccination, he may not adequately motivate this patient to take vaccination. Many adults would remain unvaccinated because they are unaware about the benefits of adult vaccination. We have to explain them about the cost-benefit ratio. As Indranil was talking about the cost, 2,000 rupees cost, 1,500 or 2,000 rupees cost for influenza vaccination. It is far cheaper than one therapy cost if he develops influenza.
Exactly.
Look at the complication that influenza can create. If we can show this kind of calculations or explain our patients about it, I'm sure the vaccination pickup would improve. There is definite controversies go on regarding adult vaccinations, especially in countries like ours, especially with this WhatsApp universities and social medias about some side effects and some issues, and probably it is hyped to such an extent that there's a lot of fear about taking these vaccinations. Healthcare providers also are inadequately knowledgeable about this adult vaccination recommendation, as there is a lot of confusing guidelines available. Suppose the patient has got diabetes and renal failure, and if you look at the guidelines from RSSDI and you look at the guideline from the Nephrology Society, though it may give the same message, the language is different, and the provider gets confused and he misinterprets and misunderstands the issue and is not able to give this vaccination. I get amazed by those pediatricians. I have not seen any pediatrician whose file does not mention about vaccination. At least one part of that file is dedicated to vaccination with those dates given. I think it is a time we adult, vaccination believers or providers would develop such a guideline. And in fact, sir, I have that in mind for almost 3 years now, that I want to develop one app. The minute patient takes one vaccination today, he gets reminders for all other vaccination with a time frame on that, and it comes in their Google Calendar, and he gets reminders for vaccination. I mean, if you can develop, I think it is not really difficult to develop such kind of simple apps or simple softwares, and that could probably go a long way. When I look at when I talk to my patients about vaccination, and various interesting things come out, which is of course published in various journals about barriers of adult immunization, and they say we are healthy, we don't need vaccination. It may not be available. My doctor has not told me where do I go and take it. It may be costly, it may be painful, it may be associated with side effects. And every one of us, each one of us has to come out with common solutions. We have to come out with social media messages, etc., and make people aware. Now, if we address those issues, if we identify these issues and come out with rational solutions, I think it will go a long way and we'll be able to easily imbibe this culture in adult vaccination as well. Thank you.
Okay. Still, Agam, I think it's a process in passing. Just think of the controversies against mobile use in the early days. It causes heart disease, even it causes brain tumor. It went on like this. Nobody utters those questions right now.
Yes.
So this resistance against something new, it's natural. And it will be, with evolution, it will be covered. But before the next question, Agam, have you taken patent of the app that you are proposing?
No, sir. That's going to be ICS APIs together patent. I mean,
can I go to that?
I think most of the pediatricians have that reminders coming to the mobile and all. Once that, I think it is very easy if you can incorporate that into the system. Because we do get the reminders from the pediatrician about the children's vaccination once we get one vaccination.
See, reminders are coming from departmental stores now. So it is very easy. Will you go to the next question, please, Rupsa? Next one. Okay. So in Runil, what Agam said is the total general, social, and say epidemiological aspect. How we get personal, how to establish early vaccination discussion and documentation in patient's journal. Single patient, individual patient, they make the total patient. How to get there?
So, sir, when it comes to the, say, doctor's perspective, when we see patients, the patients of asthma, COPD, or smoking, a written prescription, a digital or written prescription is very important. We have to write that, please do take this vaccination. And what we do, we can give a chart of the vaccination, adult vaccination chart, or write it in our prescription. The other ways maybe is that there are some annual health checkup, there are some wellness center where they can be advised about the importance or the types of adult vaccination that they give. So again, another way that maybe when they go for major surgery or surgery, just like in gynecology, you see, when they go for delivery, they will be told that these are the vaccinations that you should take. In any way, for major surgeries, you can advise the patient about the pneumococcal, the influenza vaccine, the Tdap, and other things. Then again, probably these are the things by which we can go for early vaccination discussion, and documentation is important in that way, sir. We can write and have a chart for the adult vaccination.
So what we can do as we look for pulse, respiration, temperature, blood pressure, similarly vaccination status, every time for every patient, documented. That is a plan. Yes, Agam.
Sir, if I may say, I have started a small, way of convincing my patient about vaccination. Is on the discharge card, there is just a stamp put vaccination. And, a lot of these patients are given vaccination during their discharge. And if for one or the other reason, if I have not given them vaccination, at least patient would inquire about it. There is some visuals which are kept in my OPD. I have a habit of vaccinating all my patients. So I believe about 1,200 odd patients take influenza vaccination every year from my clinic. That would mean probably 2 or 3 patients are taking vaccination every day in the clinic. So when somebody is given vaccination in the OPD, rest of the patients would want to know what vaccine, what injection is given to him, which is not given to me. And they would come and talk to me about it. Trust me, every patient walking into your OPD is the candidate for vaccination. He's coming to you because he has got some chronic respiratory problem. And not only that patient, but if you go a step beyond, all relatives, we don't get patient who comes alone. Every time you have a COPD patient or ILD patient or bronchiectasis patient or uncontrolled asthma patient, is accompanied by one or the other, family member. And it would be the right time to even talk about vaccination to society. That may be the way. And I have probably have a lot of success rate in giving vaccination to even patients' relatives who are maybe stable diabetic, stable hypertensive, and not my patients. I think all we have to do is just care, just talk to them at length about it. And as you rightly said, I tell them that I have taken vaccination, all my staff take vaccination. We've been doing it for the last 15 years. And when they listen to probably that statement, that probably convinces them to take vaccination.
And I will tell you about two doctors. One is Vivek Nangia, Delhi. Gives vaccination to his patients as Diwali gift. His Diwali gift is vaccination.
Wow.
Second doctor is me. How did my vaccination practice has changed over the years? Practically, say even 5 years back, I used to give vaccines to those who are more ill, who are more comorbidity, and who are a bit upper socioeconomic class. I considered the lower socioeconomic class that they should concentrate more on healthy lifestyle, hygiene, and other preventive therapies. But now I am actually spreading it that vaccination is part of a healthy lifestyle. And then actually there is no resistance. It depends on my conviction. And they understand one influenza vaccine, one pneumococcal vaccine does not cost much as one day in a government hospital. So no question of corporate and private sector. May I go to the next question, please, Rup sir? And again, Paramech, may you also focus on benefit of vaccination as a tool in reducing antibiotic use and microbial resistance?
Yes, sir, definitely. As you mentioned, Dr. Vivek Nagia, my prescription practices also started from the days when I was working in Fortis along with Vivek Nagia. And also, he's a very good infection control practitioner also, as you would know. He will talk about antibiotic stewardship and all those things. So these kind of practices, definitely you learn from your peers, definitely. So as far as this, coming to the question, benefit of vaccination as a tool in reducing the antibiotic use. If you take a pneumococcal vaccine, means you are definitely bound to have reduced number of infections. When you have reduced number of infections, you have reduced number of hospital visits, OPD visits, or even admissions. And your exposure to the antibiotic will be definitely reduced. For that matter, if you are getting vaccinated with an influenza, your chances of acquiring an viral infection, influenza, is very minimal, and unnecessarily exposing the antibiotics to you. Every one of us definitely will be prescribing at some point of time antibiotics for a flu patient also, whatever guidelines or whatever restrictions that we do, because of some other reasons, like the patient may be coming from a long distance and he may not be able to review on an early basis. So unnecessary exposure of antibiotic is definitely reduced in that case. And if you say a patient who is admitted to some other to the hospital with some other reason, and if he is vaccinated, then his chances of him acquiring an infection through the hospital, be a resistant bug or even a non-resistant bug, a resistant pneumococcus or a non-resistant pneumococcus, is actually reduced. Or even the immunogenicity to other bacterial infections is also better for those patients who are getting vaccinated with a pneumococcal vaccine. So the antibiotic resistance, it's basically is one of the major tool in the antimicrobial stewardship program. That is basically the prevention of infection, so that you don't get exposed to multiple number of antibiotics, and the multiple number of exposure to the antibiotic definitely paves way to the emergence of resistance. So in short, definitely it is going to benefit.
Actually, there is a limitation to antibiotics even if it treats the infection, it does not treat the inflammation. So even treated pneumonia has a higher mortality, short-term and long-term, due to the current inflammation, even if we can combat the infection. Okay, that brings us.
Sir, if I may say, with your permission, I was reading one article in Nature, which came about 2011-2012, and it says the top 7 threats to existence of human race. For your and my existence, the top 7 threats, and amongst the terrorism, the pollution, the population, etc. One threat was growing antibiotic resistance. And I read a very beautiful quote which says that one wrong prescription of antibiotic, which may be because of a variety of reasons, many a times, and in COVID time, everybody, let's probably agree that everybody has done that. Knowing that this patient does not require antibiotic, we've used those azithromycins and clarithromycins and whatnot, whichever antibiotic, that came on pen, we have used it. And this wrongly used antibiotic is death warrant for our next patient. So if you want our future generation to get benefit of this golden era of antibiotics that we had in last 6 decades, the pipeline is dry. Unless we understand and rationalize the use of antibiotics, we are going to have tremendous microbial resistance and future is doomed. So vaccination would be one big strategy which would reduce the overuse of antibiotics or misuse of antibiotics. I completely agree.
Very timely message, Agam. And actually, I had read that article, that top 7 threats. I think tuberculosis was also there probably with those 7. Tuberculosis was there. Anyway, we'll come now very quickly. The next one, please. Straight Indian recommendation on pneumococcal vaccination at present. Brief and summary.
So, sir, it's about the evolution of the Indian recommendations.
Yes, so, very quick. Very quick.
So, at present, sir, in India, we have PCV13, that is the conjugate vaccine, and the polysaccharide PPSV 23. So, there are different recommendations from different geriatric society, the Indian Chest Society, the Association of Physicians of India. In fact, it was the ACIP who initially did the initial part, because it was in 2010 when ACIP did about the PPSV 23 in adults, and then a 5 years booster dose after that. Then 2011, the PCV13 was FDA approved, and in 2012, the ACIP then recommended PCV13 and the PPV23 after, say, in immunocompromise. So, coming to our society, the Indian Chest Society, the guidelines that were made in 2019 onwards, where we recommended that in adults above 50 years, we took the age 50 years, and in fact, the 50 years we have downgraded it from the, they say 63, there is the 65 years that was there initially, because we thought that 50 years was the most important crucial time that we should be starting with the pneumococcal vaccine. And with that the PCV13 should be given first when we are recommending PCV13 and PPSV 23. So PCV13 is to be given first, followed by at least 2 months to 1 year, within 1 year, that the PPSV 23 is to be given in vaccine naive subjects. In patients who have already received the, so that has been already discussed by Dr. Kaul, and how that in patients who have received PCV 23 or PCV 13 first, what the vaccination should be.
Now it's a summary, Indranil. So our audience needs a summary. So summary is 13 first, followed by 23. Because the PCV13 serotypes in elderly is not that common in India as common in USA, where they changed the guide. But again, ACIP has changed its stance. So presently we are supporting this 13 first because it's a conjugate vaccine, followed by the polysaccharide one. If the patient is very ill, it can be given after 8 weeks. If the patient is okay, we can up to 1 year. Okay. I will come to Parvez. Parvez.
Yes, sir.
The next one for you, influenza. Rupsa, the next question, please. So, Parvez, summary, influenza vaccination, all this.
Okay, sir. Sir, quadrivalent versus trivalent, I don't think there is any confusion about it. Quadrivalent definitely has a distinct advantage by covering an additional lineage of B. And now over time, it has been more prevalent that trivalent is actually not available at all now. So quadrivalent is the way forward, and it is just in case you are dealing with a strain which is not present in the trivalent and that is circulating, then you will be giving no vaccine coverage, vaccine safety to the patients. Once yearly, twice yearly, the current recommendation is once yearly, but there is a lot of noise being generated by people who are living in the tropical region where there seems to be a subclinical circulation of influenza all through the air. And there are lots of people who believe that we could give it twice a year. However, right now, the only recommendation of giving it twice a year would be for somebody who travels to an area where there is a different seasonality. Like somebody has got a vaccine for the Northern Hemisphere in Canada, and he comes over to India, say in summer, and he would be the person who would better be vaccinated for something where he is actually going, and that is the place where the influenza is likely to be circulating. So timing SH versus NH. NH obviously is given pre-winter and SH is giving nearly in April onwards. And there are many places which are actually witnessing a circulation which coincides with the monsoons. So we have to look at the regional seasonality of influenza in a particular region and give your vaccine according to the regional seasonality rather than going by SH and NH. Then on the high risk universal, since we have a difficulty in the vaccinations, ideally it should be given universally, but it should be definitely given to high risk population, and that does include healthcare workers and everybody who has a chronic respiratory disorder. Indian recommendations for adults, there is a recommendation by most of the societies in the country, by physician societies. The Ministry of Health also recommends it, but the ministry does not support the program as a part of the national immunization program. So vaccination efforts are primarily as a result of individual efforts by societies and the physicians. So they have to be done that way. And as of now, Indian recommendations are there for vaccinating people who are at high risk for complications of influenza, which would mean those with chronic respiratory disorders, chronic medical disorders, immunocompromised individuals, people at extremes of age, pregnant females, healthcare workers, and the like. So for them, there should be a prioritization for vaccination, but nonetheless, it is ideal to give vaccination to everybody. I think that answers, sir.
Yes, so summary, present guideline, yes, it is yearly. Some sector may need twice yearly, not part of our general guideline. Still now, the high risk, probably it should be universal. Okay, I'll go to the next very quickly. We have very little time. Group sir. Okay, Aga again. Future of COVID vaccination in India.
Unmute, Agam. Agam, you have to unmute.
So this question sounds very difficult to me. At least with my current understanding, I don't see the need for further COVID vaccination in India. There may be a time if there is a pandemic-like situation or there are serious cases, one may have to seriously think about it. We would need newer vaccine which covers the prevailing strains, because whatever vaccines are available does not cover the prevailing strains. And hence, I probably would refrain advising it to the current vaccination to the population now. And for those, especially healthcare workers, I don't think it.
Okay. So, Parvez,
Thank you.
Done. Parvez, what is your opinion? Future of COVID vaccination in India?
I think he's
okay.
Blocked out.
I'll go to Indranil. What is your idea?
So which one? I didn't hear you, sir.
What is your answer to this question? Agam thinks we don't need further vaccination. Agam, is that okay? Is that what you said?
So yes. It is because, sir, it's true, because the strain that is running right now doesn't correlate with the vaccine that has been prepared. So in that way, if you are giving the older generation vaccine, probably it will not protect the present situation of the COVID that is going on. So what we require is a current vaccine which is prevailing. And in fact, it like influenza, it is changing every year or every, say, 6 months or five months interval. So it is very difficult to prepare a vaccine which will be effective against this current strain. That's the problem, sir. So in that way, it is really not required. What is required is, according to the strain, if newer vaccine is produced, then we can take that.
Okay, well taken. I'll come to Paramich later. The next question, please. Rupsa. Parvez probably is absent. I will ask Agam to start with. What should we do with pertussis vaccine? Agam.
Pertussis vaccine, yes, sir. Pertussis is recommended. Childhood vaccination would not impact the adulthood vaccination. I think everybody should receive at least 1 dose of pertussis for sure. Thank you.
Paramich, your response to this? Pertussis?
Definitely, sir. Even with the in the adults also, it has to be covered despite of the childhood immunization status. Is what I believe.
Sir, should I comment here, sir? In fact, the adults that we see right now, they haven't received the pertussis vaccination in their childhood. So in that way, our recommendation should be that the adults should get the benefit of pertussis here, and knowing fully well that pertussis is one of complicated COPD or any other respiratory disease. So in that way, they should be given at least 1 dose of pertussis right now.
As part of TDAP?
Sir, TDAP contains the pertussis vaccine?
Yes, as part of TDAP?
As part of TDAP. So TDAP will be the best. So seeing alone pertussis vaccine doesn't do, TDAP will be a better vaccine for them.
So do we agree, Agam? Say yes, TDAP?
Yes, sir. Sir, we have pertussis also available. We have DTaP also available. We have pertussis and tetanus also available. We can give whichever depending on the availability.
Okay. Now, the zoster vaccine, the next, Rupsa, the next. Now again, so Paramich, zoster.
Yeah, basically right now the zoster vaccine, especially the subunit recombinant vaccine, is available in India. It's been USFDA approved for the last 5 to 6 years. And for every individual, as we know, most of us would have had the chickenpox at some point of our life. And the study says that almost 90% of the individuals at the, if aged more than 50 years will be harboring this varicella virus. So the reactivation of the varicella, which causes a herpes zoster, which causes post-herpetic neuralgia and all those things, will definitely have increased morbidity for those individuals, especially with an immunocompromised state, especially adults. So more than 50 years of age, it's advisable to get 2 doses of shingles vaccine at least 8 weeks apart will be the best thing that we can do. Yes, it's a very costly vaccine, so I don't know how will be that vaccine penetration in the community as such. I think with all these vaccine issues, because the vaccine is not being implemented in the national immunization schedule and it is not available free of cost for the adults. So it will come in a huge cost. The out of pocket will be much more for individuals. As far as the science is concerned, we can actually combine this shingles vaccine along with influenza vaccine at 2 different sites. And even the pneumococcal vaccine also we can administer on the same day itself, because these are not live vaccines. So we can actually administer concomitantly. Thank you.
Actually, again, this is a very new vaccine and relatively costly, but that is not the primary thing. Again, it will take time to get integrated into the practice. And again, probably insurance companies have to come for the coverage of vaccination so that it is accessible and available for the population. Okay. Rupsa, next question. What is that? Next, please, Rupsa. No, take the next. This is done. Take the next. Okay. Answer one by one. Agam first.
Yes, sir, I prescribe vaccination and I give them from my clinic. And I've seen that when I prescribe vaccine and if I don't keep it in my clinic, at least 50% of the patients probably do not end up taking it for a variety of reasons. I would recommend that every chest physician must store these vaccines in your clinic and must give it from your clinic to your patients. Thank you.
Paramit.
Yes, definitely, sir. I am practicing in a multi-specialty hospital, and knowingly or unknowingly, the vaccination room is just across my OPD. So it's very easy for me to monitor my patients whether they got vaccinated or not, and it's very easy for me. So yes, from my clinic itself.
Do you come through that OPD before you enter your clinic?
Pardon? Sir.
The joke, leave it. Okay, Indranil, what you are doing?
So, sir, I had a pediatric background. So I am very well equipped in vaccination and I'm fond of the vaccination. So not only that, sir, in my clinic, but in my government hospital, I have made them to procure this vaccination because there was a government supply influenza vaccine, which was there for the hospital pilgrimage. When there was few of the vaccine left, I at least told my MS sir to bring those vaccine in my hospital so that I can give it from my OPD. That was that. And I gave that from my OPD.
Okay.
So I do it myself.
I want to know a little general scenario. Agam, what do you think about your colleagues? Are they practicing the same or no?
Sir, I missed your question.
What you think about your colleagues in general in Mumbai? Are they practicing this, yes or no?
No, sir, there are a lot of issues. It sounds very easy. Storage is an issue. Giving vaccine is an issue. Biomedical waste is an issue. Everybody may not have associated hospital and you have your own clinic. When you're giving it from your clinic, you have to specially have, because otherwise there is nothing that you create biomedical waste in your clinic. If you're giving injection, like in my OPD, there is no other waste which is generated.
Yes.
So I have to take a separate registration with biomedical waste. And that creates, so there are some practical challenges. In Mumbai, not many are giving from their clinic, but yes, I would recommend so.
Paramit, what is the general scenario? Paramit.
Pardon, sir?
What is the general scenario in
General scenario, yeah, we have conducted a CME last month only in my hospital, and I would urge almost everyone to do so because most of we have got physicians who vaccinate people, and our vaccination protocol for the gastro people, because ours is a major gastro and cardiac center, is in place for especially for those who are having chronic liver disease and those who are waiting for the transplants, the renal transplants, the cardiac transplants. All these patients definitely will be having. But as a general, the vaccination prescription is abysmal, I would say.
I think so. Some specialties are ahead, particularly nephro. I think they are much more ahead with vaccination. Indranil, anything to say?
Yes, sir. In this part of India, I'm telling you, most of the pulmonologists or the physician do not give the vaccine themselves. There are some barriers, I'm telling you. What Agam really highlighted is storing of the vaccine. So procuring is easy. What they do is tell the pharmacy house where they sit, please procure the vaccine, you give those vaccine, which ideally should not be, and the vaccination should be done by the doctor themselves. So procuring the vaccine, finding the right person who gives the vaccine, storing the vaccine, disposing of the waste are difficult and again time consuming. For example, if they want to give a vaccine, by that time they may see another patient. Many patients are waiting.
But you are doing it for the children, isn't it?
Absolutely. So pediatrics here are doing it. So why not the pulmonologist or the physicians at large?
Okay.
So then there are other issues. Suppose if you write pneumococcal vaccine and he goes to pharmacy will tell you, kaun sa wala chahiye? We have a sasta wala and a mehanga wala. We have a PPSV 23 and 13. And then if you have written 13, he would say, but then we have a cheaper one also. And then the patient would make that pharmacist talk to you here in a busy OPD, you have to answer that. And there are a lot of issues, and then this vaccination never happens. Unless you give it from your clinic, the vaccination program is not successful.
Okay. Now, we frequently accuse our government that our government should come with an universal immunization program for adults as in children. But again, government has many other things to do. So what we are doing about it? Next question, please, Rupsa. Just in the idea, Agam, starts from you. How do we communicate with our government to come with an adult vaccination program?
Sir, that's a very interesting scenario that you put forth. Sir, as a part of Geriatric Society of India, I was the president a year ago, and we developed a geriatric vaccination protocol. And we went to government and banged their doors multiple times. But as you said, they have a lot of other things to do, and probably it was not accepted. We have developed the vaccination program. We have developed a IMA, Indian Medical Association vaccination booklet, which is, the pediatric to geriatric, the complete vaccination guideline. Of course, we gave it to government, but we've got no reply from them. API also has developed one, immunization guideline, which is not very well accepted by government authorities. I think government will have their own barriers. We don't have to wait for them to probably approve this program or incorporate this program into their system. If you and me start vaccinating, if one doctor today who's attending this program gets motivated to keep this vaccination in his clinic and promises me to stimulate or motivate one of his colleagues, I think my program is done. I think that is going to be the success of today's program. Whatever 1.5 hours of time that Ghoshal sir is invested for us would go right way if everybody takes a pledge with me to vaccinate all your COPD asthmatic patients and motivate one of your colleagues to issue vaccination from their clinic. Thank you.
Okay, so our past president, APJ Kalam, had an unique style. Whoever used to get to his lecture, he had to promise that he will buy 2 books that day. So his lectures were free, but you have to buy 2 books, any 2 books. That was APJ Kalam. So anybody who is listening to us, please get it, just proceed it and share it with another colleague and just converse him. And that will be enough success for us for today. I'll go to the last slide. Rupsa, the last one, please. So we have miles to go. And we understand the need, high burden of vaccine preventable diseases.
Thank you.
Increasing elderly population, probably early immunosenescence in this part of the world, and emerging antibiotic resistance. We know the barriers very well. Actually, it is said, if there is no obstacle, then there is probably no effort. So obstacle proves that effort is there. So probably cost, I don't believe it much. Insurance coverage is an issue that should be a people's movement, not waiting for the government. Lack of adult vaccination centers, very practical, real barrier. But on the whole, it is the inertia in mindset, in changing practice. And the way forward, as our elite panelists, Parvez, Agam, Paramej and Indranil have highlighted, mobile vaccination centers, active collaboration of all stakeholders, but again, primarily it is the awareness and the conviction of us physicians that we need this vaccination for our patients' benefit. If we believe this, that will be percolated to the patients. And I again request all our colleagues and audiences who are tuning in to this webinar, just spread this message. Vaccination prevents morbidity, mortality, and promotes health. Adult respiratory vaccination is not a myth. It's a very real, regular practice. Now I thank you all, and before concluding, I'll take Indrila to give the thanks for everybody. Indrila, please.
Thank you so much, sir.
No, before Indrila says something, I must put it on record, sir. That was the excellent moderation. Success of any program depends on the moderator, and you've done it so well. So on behalf of Parmez, Indranil, and of course Parvez Bhai, I thank you for doing this for us. Thank you.
Thanks, everyone. Yes,
very much, sir. Over to Indrila.
Yes, exactly, sir. Thank you so much for this wonderful moderation, and to all other faculties, Dr. Parvez Kaul, Dr. Agam Bora, Dr. Paramez, Dr. Indranil. Thank you so much for taking out time and supporting ICS in this endeavor. And as for our audience, thank you for joining us. Please feel free to write to us on icsofficeexecutive@gmail.com. Keep watching us. Stay tuned while we come up with our next webinar on pediatric asthma on 27th of May, 2023. Please join in large numbers, post your questions, and interact with our esteemed faculties. I thank our faculties once again for making this webinar successful. We hope to carry these endeavors forward. Thank you.
Thank you, sir. Thank you.
Thank you. Thank you, sir. Good night.
Thank you all. Thank you, sir.
Thank you.
Have a great weekend. Have a great weekend.
Thank you so much, everyone. Thank you for sharing such valuable insights. And I have a short video to share with you all. Thank you so much for your patience. ClearNet is India's largest live digital CME and doctor-generated medical content platform. Our website is www.clearnet.com, where we have lots of live sessions conducted by eminent speakers across the globe. And we have MedWiki service, which is medical Wikipedia for doctors only, that also you can read at your leisure time. We will invite all the doctors to visit our website. And for today's session, thank you so much, everyone. We are more than grateful to everyone present here, and we hope to have you again for our next sessions. So with all your permission, I would like to sign off for today.
Thank you.